What's up, everyone? My name is Hunter and I am a first-year emergency medicine resident. I saw this video on my feed over the weekend and figured I should react to it. So let's get into it.
If you've ever watched The Pit on HBO Max and thought, I could do that, hold on, because there's a massive difference between being entertained by ER chaos and actually thriving in it. Dr. Jubal, MedSchoolInsiders.com. Actual emergency medicine doctors have praised The Pit as one of the most medically accurate shows ever made. It doesn't...
I can agree. I watched the entire first season of The Pit, and it is very medically accurate, except I'll wait and see if he explains. There's a big piece of the show that I feel is not accurate.
Doesn't sugarcoat the reality, but here's what the show can't tell you: whether you're actually built for emergency medicine. The key to excelling in any specialty isn't GPA or test scores, it's whether your fundamental
Okay, it doesn't sound like they're going to go too far into The Pit. From a medical standpoint, it is very accurate. I will say there were multiple scenes where they were putting their stethoscopes on the wrong way, which I don't get how shows haven't figured that out yet, especially with physicians that are on set and overseeing the filming of these shows. Like, that just irks me. But one thing that The Pit gets wrong, which they do on purpose, is that the first season covers what is supposed to be one shift in the ER, and every episode is 1 hour. And while we do see all of the acute things that are shown in that show, it doesn't all happen in a single shift like they portray it to. So this is like a 12-hour shift over their 12 or 13 episodes, and we might have 1 or 2 of those very acute, very sick patients in a shift, but you don't have one every single hour. I get that they had to do it to keep every episode entertaining, but that's like one caveat to the show.
Personality and core skill set align with it. Today, I'm revealing 5 signs that will tell you whether you're built to succeed in the emergency department or destined for burnout. The first sign you're built for emergency medicine is that chaos doesn't drain you, it energizes you.
I would have to say that that is completely accurate. In emergency medicine, you are surrounded by chaos all the time, and if you tend to kind of freeze up or shrivel into the corner when things are happening, this isn't going to be the specialty for you. I would say that the stereotype fits that emergency medicine physicians are adrenaline junkies, and part of that is that we're seeking some of that adrenaline on shift.
The focused environment of the operating room or the steady, scheduled appointments of a primary care doctor, the emergency department is a constant whirlwind. Here, you're expected to juggle everything at once. Expect high-pressure moments straight out of The Pit. Multiple patients arriving simultaneously, priorities shifting every few minutes, and constant interruptions pulling you in entirely different directions.
This is also why we get pegged as the physicians that have ADHD. Very accurate in my case, but you're constantly having to shift your mindset on the priorities of which patients you're seeing first, which problems or fires you are putting out, and it's actually such an important aspect of what we do that it's now being tested in our boards in kind of like an OSCE style format. We are tested on our ability to triage situations and prioritize tasks in the proper order.
That intensity is exciting for some and a nightmare for others. If you rely on quiet, order, and predictability, the ER will burn you out in no time. On the other hand, if the chaos leaves you amped up and unwilling to clock out, then you found your specialty.
I think that this is very evident in my videos, all of my previous vlogs, that this specialty is something that invigorates me. I leave all of my shifts very excited and almost feeling like I could continue working for another few hours, especially when I'm leaving the emergency department. and I think it's very evident in the vlogs. I have been recording every single day of my residency program so far, starting with orientation, which you can find in a link in the description below to the playlist that contains all of my weeks of residency thus far.
Thriving in that chaos requires something else. You need to love variety, which brings us to our second sign. Emergency medicine doctors are the ultimate generalists. They're treating heart attacks, psychiatric crises, pediatric traumas, and kidney stones all in the same shift. They know a little bit about everything. Many say emergency medicine doctors are jack of all trades, masters of none, except this isn't quite true. They specialize in breadth and acuity, meaning they are the masters of resuscitation, stabilization, and rapid critical decision-making across organ systems and age groups.
I think that this is also very accurate. We do have to have a very broad depth of knowledge that covers, every system of the body, and from pediatrics, even neonates, to the elderly, and having a good understanding of the acute conditions that can present in any capacity is very important to what we do.
Think airway management, hemodynamic stabilization, and initial trauma and sepsis resuscitation. The stereotypical EM applicant is the medical student who loves every rotation. If you're having trouble narrowing down your options, I highly recommend specialty.
This is really funny because as a med student, I was interested in every specialty. I actually thought that I wanted to go into orthopedics, but as I started doing my rotations during third year, I found little bits and pieces of each specialty that I enjoyed, and here I ended up in EM, so that part was spot on.
Quiz.com, which aligns your preferences and strengths with a list of ideal medical specialties. Doctors who thrive in emergency medicine generally can't settle on a single specialty and get restless sitting still. If that's you, pay attention. If you're someone who wants to become the world's expert in one narrow field, emergency medicine will feel frustratingly shallow. It's not uncommon for specialists to be frustrated with emergency doctors. An orthopedist might critique a splint, a cardiologist might question a cath lab activation, or a surgeon might nitpick the workup for abdominal pain. Specialists.
Now, this might be true in some institutions, but it's going to be variable depending on where you are training and where you're deciding to work. I have found that I will get pushback from some consultants when I'm calling them from the emergency department, but for the most part at our institution, they understand what we are operating under and kind of everything that we're having to deal with besides the single patient that they are calling about. And I really haven't had anybody, nitpicking my workups or questioning why I consulted them. So that's going to depend on where you are training, where you're working, but so far I've had a great experience with consultants from the EM side.
Focus on depth, precision, and long-term outcomes. EM doctors specialize in speed, stabilization, and buying time for definitive care. The doctors who prosper here are those energized by constant mental pivoting. Next, are you quick and decisive?
I think that's super true. You have to be, kind of that ADHD mindset, able to pivot from one task to another. Something more pertinent or urgent might come up and you'll have to drop what you're doing to go do that and then remember to come back and finish what you had started. And I think it was a great point in that last section that when you're practicing emergency medicine, we are very good at initial assessments and resuscitation, stabilization, but then general workup and caring for more chronic illnesses and things that aren't immediately life or limb threatening are kind of outside of our wheelhouse. We're having to deal with a lot more of it in more recent years, but it's definitely not what we're specialized in.
Under pressure, even with incomplete information. Here's what that looks like. A patient walks in complaining of chest pain. It could be a heart attack. It could be anxiety. It could be heartburn. You have minutes, not hours, to decide on an immediate treatment plan that could be the difference between life and death. The doctors who struggle in the ER are those who need total certainty before making a call. The ones who succeed are those who can rapidly synthesize limited information, make a decision, and commit to a plan even if they're not 100% sure. To make it here, you need to channel your inner Dr. Robbie. You need to be someone who constantly makes split-second calls with incomplete data, knowing that waiting is simply not an option when a life is on the line. But
I would say one critique I have of this is, yes, you have to have a decisive personality and be able to make those quick life-saving decisions in these situations, but in a way it is something that can be learned. I know on my first few shifts in the department, I would see some of these sick patients and just kind of freeze and look to my attending or senior residents because I just had no idea what to do. And as you get more seasoned and develop your clinical gestalt, it's a lot easier to make those decisions in the moment without hesitation and be able to practice emergency medicine the way that it's designed to be practiced. And so I don't know that being indecisive is something that should turn you away from the specialty, because it's definitely something that can be learned.
But quick thinking alone isn't enough. You also need to handle something most doctors can't. If you're destined to be an emergency medicine doctor, you need to be able to manage patients who are at their absolute worst. You'll deal with aggressive patients, violent situations, people high on narcotics, and mental health emergencies. And unlike other specialties in which physicians can decline patients or refer them elsewhere, you can't turn anyone away.
This is actually one of the reasons that I love emergency medicine. We're not thinking about what insurance people have, or being able to decide not to see someone simply because of how they're acting. We treat everyone and we treat them all the same. And it's also a very important aspect of our job to have good bedside manner and be able to navigate some of these more difficult situations.
The Emergency Medical Treatment and Labor Act, or EMT-ALA, legally requires you to see everyone who walks through those doors. Everyone. That means verbal abuse becomes routine, and you're at a higher risk of physical harm from patients than almost any other specialty. Beyond the immediate danger, you will also witness the same preventable tragedies on repeat, often rooted in larger social crises like homelessness, addiction, and domestic violence.
All of these things are issues that we deal with in the emergency department, but I tend to look at them from a different perspective and try to sympathize with where people are coming from. As Kevin mentioned earlier in the video, people are in the emergency department on what can be the worst day of their life, and they're in a very vulnerable situation. And just understanding that and trying to step into the patient's shoes before having any judgments about their background or what brought them into the department can help tremendously, because all of those things don't matter when it comes to making the clinical decisions that we're making. And trying to be as unbiased as possible when looking at the scope of a situation has helped me tremendously when it comes to just working up a patient based on what they're telling me and what their studies and data are showing.
Great things happen.
Sorry, I don't pay for YouTube Premium. Gotta skip the ads.
This sustained exposure to trauma and abuse can eventually wear you down mentally and emotionally. The doctors who last are those who can maintain compassion without taking the darkness home every single night.
I think this is absolutely true. I am very green when it comes to my experience with all of this, verbal, sometimes physical abuse. I was actually assaulted before I started medical school while working in an emergency department as a patient sitter. So these are things that we see, but I think it's super important not only to find the light in our careers, but also to having a life outside of medicine that we can come home to. So for me, it's staying fit and then being very present with my family to prevent burnout. It's been very helpful so far in residency.
And it shows in the numbers. Emergency medicine has the highest burnout rate of any specialty at 63%. We break down exactly why in our specialty burnout rankings video, link in the description. But it's not all darkness. There's another side to emergency medicine that appeals to certain personalities, and that's being comfortable with procedures. A lot of them. Emergency medicine is hands-on, but not surgical. You'll still be doing more procedures than most non-surgical medical specialties. Here's what that looks like. Incision and drainage of abscesses, lumbar punctures, suturing lacerations, reducing fractures, and thoracotomies. Some would say you're in that sweet spot of being more procedural than internal medicine, but less than surgery. The key difference is that these procedures are a means to an end. You're stabilizing patients, not perfecting a single surgical technique over decades. If you love being hands-on but don't want to spend 5 to 7 years in surgical residency, or if the idea of doing highly complex but repetitive procedures for the rest of your career doesn't excite you, then emergency medicine might be a better fit. You'll perform quicker procedures with more variety, albeit with less complexity or finesse. Just know that closure is rare. You might stabilize dozens of patients in a shift, but never know what happened to any of them after that. Which brings us to...
This was another reason that I chose emergency medicine. I really like working with my hands and wanted to be able to do procedures, but didn't want to only work on one aspect of the body. I found orthopedics was very interesting because I really liked MSK anatomy, but the procedures were much longer and less exciting than they seemed to be made out to be in the media and like going through med school. So doing procedures is a huge pull for emergency medicine, but they're quick, they're pretty easy, and we get to do a couple per shift.
Our final sign. When a patient comes in with a heart attack, your role is to stabilize them and keep them alive through the most dangerous moments. After you hand them off to cardiology, their story continues, but you're no longer part of it. You might never know whether they went to the cath lab, whether the intervention worked, or whether they made it. And you certainly won't see them at follow-up appointments, and whether they changed their diet or kept taking their medication. For some doctors, this is freeing. No long-term management, no chronic disease coordination, no longitudinal relationships to maintain. For others, it feels incomplete, like reading a book but never getting to the last chapter. Psychologists call these open loops, unresolved stories that the brain naturally wants to close.
I think this is an absolutely true aspect of emergency medicine. We don't 100% have longitudinal patient care, but sometimes we do. We have multiple patients that come back time and time again that we do develop patient-physician relationships with. And more we are dealing with chronic diseases in the emergency department. It's not meant to be that way, but it is something that we are having to do a lot of, as a lot of people aren't able to access primary care in a feasible or timely manner, and so the emergency department becomes their source of primary care. It is an argument that it shouldn't be that way, but I can't do a whole lot about that, so the way that we're training is to be able to do some of that more primary care on top of the more emergent and acute situations that we deal with.
In emergency medicine, you have to get comfortable leaving those loops open. You stabilize the crisis, set the patient on the best possible trajectory, and trust that the system and the specialist will carry it forward. You rarely see how the story ends.
Apologies, my camera battery died, so I'm hoping that everything's saved, and we will continue.
Watching the pit and thinking, this looks intense? You're right. But does that intensity excite you or fill you with dread? You won't know which camp you're in until you've actually worked in different specialties. That's why getting clinical exposure as early as possible is critical to making the right decision. If you're unsure whether emergency medicine or any...
Well, that about sums up the video. I thought this was really good. It pointed out some kind of personality traits and aspects of the job that not everyone thinks about when they are considering the specialty as a potential, career. But most things were quite accurate. We are very much kind of like fitting a stereotype of adrenaline junkies that are able to task switch and prioritize things in a very quick manner. We're decisive and primarily deal with resuscitations and stabilizations. Don't have a ton of longitudinal patient care, but do have some physician-patient relationships that go on over time. But yeah, I thought it was overall a very good video. I'll give it, I'm gonna say like an 8 out of 10, because there are some like biases that I always feel when I watch Kevin's videos. But yeah, overall, good job. I've got a vlog coming out on Sunday. We'll catch you in the next one.